So obviously, growing up in a medical family, my father was a doctor. So we lived within sort of hospital premises. So you're sort of part of that family. For instance, you know, the earliest memory I can remember is when I was about 7. We lived above the accommodation was above the sort of maternity wards. My father did obstetrics, and sort of, you know, in those days we didn't have such restrictions. You'd go down, you'd meet the ward sister and everything, and it was just like a big family. And sort of Christmas time, the doctors would go around and they would have a sort of fancy dress. They'd go around and dish the food out to the patients and everything. And I just loved being in that sort of bubble. And then following on from that, when I had my first child, I was so amazed by the way the midwife looked after me and was so kind to me. I thought, this is what I want to do. And that really sort of got me into that health sort of, you know, I wanted to be a health professional of some sort. I trained in North Wales, University of North Wales, and I'll tell you about my interview. So when I went for my interview, you know, I was this young sort of, I think about 20 at the time, and the person who interviewed me, it was a male, obviously he was a male nurse, and we went through the interview and everything, and it was okay. And the last question, he asked me a question. He said, well, yeah, you know, you want to come into nursing, but what will Granny want? Will she want more babies to bounce on her knees? And I was really taken aback, you know, so how do I respond to this? And I remember, you know, I was so taken aback, I couldn't respond. I just smiled and that was it. So yes, so that was sort of my first sort of encounter, I suppose, which at the time I didn't realise, but it was a microaggression, obviously. And obviously he was the director of services at that time. So when I started my training, every time I saw him, I had this memory that, oh my God, you know, I can't get pregnant, I can't have another child. So that was the thought processes going on sort of during that time. But other than that, it was a good 3 years that I went through, made some really good friends, you know, with the other candidates, with the other students. But when I look at my photograph when I qualified, I was the only, you know, there's all of us. There was, I think, a cohort of, 20, 25 of us. And there's me sitting in the middle, the only brown face in the picture. So yes, at the time, I don't think I was immature or I didn't realise. But when I look back, maybe, yeah, I was made to feel different, probably. I was lucky because in those days, where you trained, you usually ended up with a job in that institution. So I secured a job, and I did my you did like an internship. You had to do 6 months surgery, 6 months medicine. So I did that. But when I think of it, because I was always fascinated by surgery, and so I did my surgical sort of internship or placement. And I really wanted to go on. At that time, there was a sort of a program, a surgical sort of for specialists. And I put my sort of, I put an expression of interest that I would like to go through this pathway. But but the answers I got from the sort of senior team at the time was, okay, yeah, well, you have to wait your turn. You know, there's a backlog. There's other people wanting to go on it. But I always felt I didn't have the courage to pursue it. It was that I couldn't put my finger on it at the time, but that's probably, again, because of maturity. And I think I felt that I couldn't speak up or I couldn't request because I felt different. Because I was the only one there who was brown and everyone else was, you know, was white, Caucasian. And yeah, I didn't sort of go ahead yet. I wanted to, but I didn't have the courage because, you know, you got a rejection first time and you thought, oh, you know, I'm not going to go ahead with it. Because I was married to a doctor, I didn't stay because he was moving around. So I went to Birmingham following that. This was in Wales. So I went to Birmingham after about a year and I got onto a programme which was anaesthetics and recovery. and that was a year's program. And Birmingham was, for me, a bit of an eye-opener, because North Wales, there weren't many. As I said, I was the only brown person there. When I went to Birmingham, it was a bit more diverse. There was a lot of our black colleagues, and it was much more multicultural. Sorry, and Birmingham, I enjoyed the time I spent there, but it's what I saw. It wasn't about sort of me. It's about sort of the two-tier systems going on with the patients and everything. And I think I was in theatre, so I wasn't out on the ward there. So theatre is a bit different, the environment, because you're within a closed sort of compound, and the patients are sort of under anaesthetic. Because my job or my role there was to learn about, when patients were put to sleep. So you didn't really see them. You only saw them for a short period of time. But then I did that, and then after a year I went onto the wards, and during that time I saw sort of the difference in the way patients were treated. And yes, I also felt at that time that career-wise, no one guided you. There was no one there, although you saw your fellow colleagues getting on pathways, getting on career sort of pathways and things, but I didn't know how to get on them or who to ask, but because no one told us. There was like a hidden agenda going on, and we were the ones that weren't informed of these pathways. For instance, that was the first time that I heard the comment. So, for instance, on the endoscopy unit. So I was at that time within the endoscopy unit. And obviously Birmingham is a very diverse population. So we had a lot of obviously different people coming, but a lot of high South Asian population coming in for endoscopies. And obviously people behave differently when they have interventions done. And, a lot of our ladies, they were scared, obviously. So they maybe needed more sedation than maybe someone else needed. But that's dependent on the individual anyway. But you heard the comments like, Asian women are princesses, or Asian woman syndrome, all these terminologies that I'd never heard of, but they were sort of being used. And sort of, there was one example where they were looking at the list, who was the next patient, and it was an Asian gentleman. And I heard the anaesthetist say then, we better get some more sedation drawn up, because these guys always need more. It was the way he said it, these guys. So those sort of microaggressions, those sort of behaviours. But, and you saw that across the board. You saw that, you saw the little comments, microaggressions and the assumptions. So that's sort of when you saw these things and you heard these things, but you didn't say anything. It's like you turn but you felt bad, because especially when it happened for me being a South Asian, when I heard that about other South Asians, you felt really bad. I mean, I had a chance during my career to go overseas. I had a chance to go and work for a UN-funded project and as a nurse consultant, and I took it. So I went overseas for a couple of years, and that's when I really got into public health and women's health. And I actually met the place I was at. I met at that time. He was from the London School of Hygiene and Tropical Medicine, and I got so engaged in public health, and I saw the state of maternity services overseas, and I just thought, wow, there were no maternity services, how these women suffer, how terrible it was. And I really wanted at that time to do midwifery. I thought, I've got to do midwifery. That's, when I go back, I want to do midwifery. And I want to do midwifery because I wanted to obviously have the knowledge, have the skills, and then maybe continue my sort of public health work as well within women's health. So I had the opportunity. I went ahead and did a master's in public health at that time from London School of Hygiene, because there weren't any placements available for midwifery. So I did that, and I worked with DFID at the time in women's health overseas, managing a few projects overseas. And then I suppose that again, I saw how things were, in the developing countries, and how maternity services was so bad, and women dying and whatever. So once I finished that, I managed to get on midwifery, and I started my sort of midwifery journey there from then on. But all those things that I sort of, knowledge is power, obviously. It equipped me for sort of things here. Oh, so I thought. So I thought. But I found that my sort of postgraduate qualification was more of a hindrance to me in my early midwifery journey.
Can you explain why?
So when I started in midwifery, again, because I was a nurse, the training it was 18 months. So you do basically a 3-year degree course in 18 months. And it was quite tough because of the timeline, because we had so many targets to achieve. So when I qualified, got my job as a midwife, I remember one of the managers sort of saying to me, because she obviously had seen my CV, and she said to me, "Oh, I see you've got a master's." And I said, "Yeah." And she said, "You don't need to have a master's to be a midwife. It's about practice. You don't need to have it." And obviously I found out later, because obviously the way in those days, it wasn't, for instance, now if you're in a senior position, one of the requisites is that you have postgrad, whatever. And it's because she didn't have one, And I know throughout my career, she was always I always was very wary of her, And to make it even worse, I went and did another master's, and that I think that didn't go down well, because again, I heard later that someone had said, "Well, of course she can do it because she's got a husband who's a doctor, so he can pay for it, unlike some of us." So these are the types of sort of things that you face, and yeah. I think throughout my career, it's the microaggressions. For instance, again, it's those same things. You work, and I know I worked. I thought I did well, and I was always told I did well on the shop floor. But when it came to, say, career progression, there were individuals who, again, and I put it down to them being incompetent, and maybe me being good at my job and showing them up or whatever, but it was things like, if you wanted to do something or go on a training program, there was always barriers. Oh, it's difficult now. The time's not right. And just being given tasks, added on tasks which wasn't fair, because you saw your colleagues not getting those tasks. And when you challenged it, if you did, you were then said that, "Oh, now you're being difficult. Are you saying no then?" For instance, as women come in, you might be given 1 or 2, but then taking on 3 or 4 is not within your remit. It's too many. But yet, I was always given the complex cases, or I was always given the cases, the complex cases, which were difficult, needed more one-to-one, and there were other people who were available to take on those cases. But they only had 2, or they point blank said, "No, I'm not having it. I'm not doing it." But if I said that, I was seen as being maybe not wanting to do my job properly. But when I saw but you knew your fellow white colleagues, that, they would say, "No, I'm not having more than 2. It's not fair," and it wasn't questioned. So little things like that. The way the network works is, you've got managers, you've got other midwives. They socialise outside, or they talk. When I went into management, I then you see that how it works. That if you challenge, if you sort of work with the establishment, it's fine. But if you challenge being a minority, you'll be labelled. You'll be regarded as challenging or aggressive, or they'll I don't know, when it comes to your appraisals, you might not have a good appraisal. You might be reported. So all those sort of things go on in your mind, because you are just so afraid of the consequences that may happen, and it'll affect your career. and you always you don't want any sort of black marks to be on your name because it lives with you. And midwifery is a very closed sort of shop, especially if you are in a particular area, it'll move around with you. We think that there's X number of hospitals, but everybody talks. There is networks. I'm very high risk orientated because of my nursing background. So my first sort of senior position was a high risk lead, and that was a new role, and not many applied. So maybe, that was why I got that role. But again, it was tough because you're put into a senior role and you're expected to just fly. And I felt I didn't get the support that I should have had. It's like you have to carry yourself. And there is no safe space to go to. There is no coach, there is no mentors or coaches for people like us. Yet you see your white counterparts having direction, having support. So it was a hard journey. Yes, I got into senior roles, but it was, I did everything on my own. That's how I see it. And I was lucky. I was lucky that I got through without any sort of blemishes or anything like that. I was out of the blue diagnosed with cancer in 2016, and so I had to go on a very long treatment program. I ended up having a bone marrow transplant, so I had quite a period of time off. And so when I went back, they were very supportive at the time. I where credit is due, you have to give it. And so I went back, but I went back very early. I realised that now, but it was something that was my choice because I just felt I needed. That was the only thing I could control in my life at that moment in time, and I love what I do. So I went back, and yes, everyone was very supportive to begin with. It was all fine. I was put into a different role, obviously, because I couldn't go back to my previous role because of restrictions and whatever. But there came a moment in time as time went on, I started to get vibes, sort of, those feelings. I think being in an environment where you're always on edge because you're always looking for things, you start to have this sort of detection mechanism built in, and I could feel sort of vibes and things happening, and I thought, and then I was told that we're going to be thinking of we're going to reassess your situation, your health situation, and decide on where we can redeploy you. So I was really shocked to hear that because there had been no conversation with me, and I was thinking, everything was all right. No one had that conversation with me. So I was really, really shocked. So shocked that I realised now I was vulnerable at that time anyway, mentally, but that doesn't matter. That shouldn't have an impact on how people treat you. So I sought help because we do have reps, we do have people within the trust to go to. And I did go, and I said, look, because I was told that there'll be a meeting, bring a rep. So I went ahead and I went to my rep and everything, went to the right people. But it was as though I was doing the chasing. So I went, told my story, and so the meeting was going to be in a few months. But I just felt they weren't building my case. They weren't engaging with me. It was me who was having to do the sort of running after them. And obviously you just, it really affects your mind, your mental health, everything. And you start to lose confidence. You start to sort of go down this hole because you start to think they were obviously talking about me, but I was thinking that. And it was as though I was a burden. That's how I was feeling. That was the impression that I was getting, that she's not an asset to the trust anymore. Yes, although I'd been there so long or whatever, it didn't matter. You weren't someone that we can invest in anymore. And that's how I was feeling. No one had said that, but I was getting those vibes. So I just made that decision there and then, which was the wrong decision. And I just said, I'm leaving. You know, it was just a spur of the moment decision because I was so upset, so devastated by how I was being treated. Although it was a silent treatment. You know, how can I explain it? It was like, yeah, people were fine in front of you, but you felt that, yeah, there's something else going on behind you. So I left. And when I announced my decision, I was even more shocked when I look back now. No one stopped me, or no one said, look, hold on, what can we do? Let's talk about this. You know, I'd been there for a long time and you know, thought I had some value, but obviously not. So yes, so it was a very tough time at that time. And I remember the day I left, it was the worst day, sorry. So I left in September of 2019, and I had that time, and then obviously COVID came. And I felt devastated because the time where I was needed as a health professional the most, I couldn't be there to do what I do best. And that was hard. It was like I'd let the team down, I'd let the side down. It was hard. It was very hard. And I really felt for my colleagues. I felt for my friends within the service. And, you know, you work all these years and this is what it's about, you know, helping people out there, being there and supporting people get through things, our patients, our women, whatever. And it was really tough. I felt really, really bad. Really, really bad. When the Embrace report came out, that just, you know, it makes you think. It made me think, and it sort of put things into perspective. Like, of course, there's going to be a high incidence of deaths within the BMA communities because we are the ones on the shop floor. If you look across the workforce, there is a lack of representation in senior positions. So most of the workforce who are from these communities are actually working on the front line, whether it be doctors, nurses, midwives. We are on the front line. And again, there was all the incidents about not having proper PPE, not having proper sort of masks, all this business. And it makes you think that, okay, was it because we're undervalued that they didn't step up to ensure that we were protected? Because that's what it feels like, you know. That's what it felt like. So, and I think COVID, the pandemic, has actually obviously shone that light, that it's not just about what we feel and what we're saying. We've been saying this for years, you know. People have been voicing this, but it's been just pushed in the corner. And when you have the statistics, not just of professionals passing away, but about this, for instance, in maternity, the statistics about, you know, black women being 4 times more likely to die, Asian women being 2 times more likely to die. It's not about them being black or brown. It's actually about the system being structurally racist. Before COVID, I was presenting at the Royal College of Midwives Conference. I was asked to present because I also am a volunteer consultant for a twinning project, which is in Bangladesh. So we support projects in Bangladesh. So I've been out there and supported the midwifery sort of workforce out there. So I was asked to present on my sort of experiences. And it's funny when I go to conferences, I always try and look out for the other brown person, you know, someone that looks like me. And it just so happened that two of my other colleagues, midwife colleagues who are South Asian, they were at the conference and they were also looking for the same. And they connected, but I didn't connect. We somehow missed each other. But then one of them, she heard about me, so she contacted me and we arranged a meeting and we met up, and it was just so so nice to talk to someone who looked like you, shared things that, you know, you shared, understood things that you understood. And then we then arranged to meet the third person. And because we all live in different areas, the other two colleagues live up north and I live sort of down south. So we decided to meet in Birmingham. And we went, as Asians do, we love our food. So we met up in a restaurant. We went in and we were there for hours. I think we were totally oblivious of the time. And we were just sharing our experiences, our journeys about midwifery. And it turned out that, and between us, there's like 3 decades of sort of 3 decades of midwifery. And it turned out, so the things that I had seen or the things that I had experienced 20 years ago or even now, the other two were experiencing the same things. And the youngest member, she's only 3 years qualified and she's experiencing the same thing, seeing the same things. So we said, hold on, you know, has nothing changed? I mean, we've had numerous reports, inequalities reports, from the Black Report to all the reports that have been published, and they've made recommendations, but you know, they've made recommendations, but there's no action. Action hasn't been done because we're still, you know, seeing the same things, hearing the same things. And in fact, the statistics are worse. I mean, obviously this Embrace report and COVID has just highlighted that. So we thought, we've got to do something. You know, we've got to do something to help our community. Our communities don't have a voice. And that's not just the birthing community, it's the professional community. So we just decided then, so the Association of South Asian Midwives was conceived then. And that was I think in October, November. So then we sort of said, right, we're going to, you know, we had so many plans at that time. We were going to do this, we're going to do a study, we're going to do research, we're going to be a voice, we're going to talk to the community. So we had all these plans and we came up with the name. And it was so funny. There was a lady next to us who was obviously, we were so engaged, we totally didn't notice anyone around us. And she said, look, I hope you don't mind, I've been eavesdropping. I mean, she didn't need to eavesdrop, we were so loud. And she said, it's fantastic what it's a really good idea, you should go with it. And she was a social worker, so she was like, you know, within our sort of profession, sort of professional boundaries. And so then COVID came and we were supposed to meet, but we didn't. But we did all the work sort of online through Zoom. And then, of course, Black Lives Matter happened. And the Embrace report happened. And we thought, this is the right time to launch. We've got to launch. We've got to go out there and do something. So we launched in July last year, 2020. Very, you know, totally new to us. I mean, it's not easy. It's like setting up a business, isn't it? We had to register. We registered, and it was a learning process for us. All the things that were involved, and of course, we had no funding, but we were determined. So we launched in July last year, and within a few months, we had so many stories from both professionals, from midwives, from birthing communities. We had all these stories, and we had comments like, "Oh, this is amazing! You know, there's nothing like this for us to share our experiences and talk about our experiences." So yes, and for me, I mean, it was like I found my tribe. You know, I found this safe space. You know, the three of us. You know, there's a big age gap, age difference and everything, but we don't feel that. We just feel like, you know, we found our space. I mean, we literally talk every day. It's ridiculous, but we do because we're so passionate about we talk about what we're doing, but we talk, we engage. And I've never had that safe space in my whole 20 years, you know, fellow colleagues, fellow midwives. You know, if I have issues at work, not issues, if you want to run something past, you've got somewhere to talk. You've got someone to, you know, talk to. And it's been fabulous. For me, I just feel like for the last 20 years, I've been a bird in a cage. And now that cage has been opened and I'm just flying because it's just amazing, the liberating sort of experience, the liberating feelings that I get because I'm doing what I love. Yes, I'm passionate about inequalities. I want to make that difference. And the other two feel exactly the same. And we've published a report, and on the back of that, it's like, oh my God, everyone's contacting us. We need to talk to you, and all of a sudden, it's like I was invisible, but now I'm not. Everyone's sort of suddenly reaching out because they want our opinions, they want our, advice, and it's quite overwhelming. Actually, it's quite overwhelming. It's scary. As a result of COVID, with the statistics about how our communities are more at risk of having adverse outcomes, it was necessary, and also about the staff being treated differently while working in the COVID situations. For example, not being given the same opportunities or the same benefits as their white counterparts have, because yes, people were shielding, people were sick, people were upset, but a lot of colleagues were made to feel that no, you can't have time off when you're needed here, you need to work, and they felt guilty, they felt they were asking something that they weren't supposed to ask. So COVID, obviously, because that highlighted, because of the deaths, the way our communities were treated, it was because it was racism. It was the system. We know the system. The NHS is a fantastic system, don't get me wrong. It is the best system in the world. But within the system there does exist this racism, and there is a two-tier system, not just only for the patients, but it's for the staff. Because there is no representation, and if you don't have representation, you won't have career progression, you won't have the power to ensure that things actually are equitable for the people that we serve. And COVID has highlighted that, because there is no voice up there. I mean, people have moved up, but sometimes you think, is it tokenism? Is it by merit? Or is it tokenism? But I think as a result of COVID, and because equality and equity is so high on the agenda now because of the outcomes, you can see in the last few months or the last 6 months, a lot of people who, for instance, yesterday, the first ever professor for nursing studies was appointed of South Asian origin. So there are people being appointed now. But then I sometimes wonder, well, now, is that another knee-jerk response? Is it really because we want them to be there, or is it because it's a reactionary thing? Because more than often, it's about tokenism. It's about ticking those boxes. So if the momentum keeps going, yes, maybe change is here. But there's a lot of work to be done. There is a lot of work to be done. So for me, because when I left, it totally knocked my confidence, and because I'd had my previous challenges, I was out, I wasn't in a good place. So I made that decision sort of just pre-COVID that no, I love what I do, and I want to go out there and still, give to the community. I love what I do. I've got time to do it. I don't want to be at home and not be part of the workforce anymore. Maternity services is going through a big transformation at the moment. And they had a big review in 2016. And one of the things that came out is women want to have continuity of care. And we know on the back of the pandemic, we know that obviously women from BME backgrounds and disadvantaged backgrounds have the worst outcomes, have the most adverse effects. So the whole purpose of continuity of care is to have that one-to-one care. Women want that personalised care. So if you can implement this within the structure and address those inequality issues, because the adverse statistics are within those communities, so it would be pertinent to go and work with them and reduce those adversities. So that's why I took this job, because it's about addressing the inequalities and working with those disadvantaged women and trying to make that difference. And I know from the midwifery workforce, there is a lot of excitement because it's a totally new way of working, but there's also a lot of not everybody has bought into it. And, you hear comments, oh, but why should they have special treatment? But it's not about special treatment. It's about allowing everybody to have equitable care and ensuring that. So there are attitudes out there because, if you can make that comment, what do you mean special treatment? It's not special treatment. It's about having equitable care. And every woman deserves that. Every patient, every woman deserves to have equitable care. The first round, when everyone was asked to clap, yes, it felt really good. You felt proud to be part of the NHS. But you have to remember, prior COVID, the NHS workers, we always get so much criticism. And the thing is, people should have been clapping for us before because we haven't done anything different. We are doing what we do. During COVID, we do that every day. It didn't, COVID didn't have to sort of highlight that because as NHS workers, that's what we do. We were doing our jobs, so for me, it was that sort of initial reaction. Wow, everyone's clapping for us. It felt strange because all of a sudden people are clapping for us, but yet people were dissing us beforehand. This has happened. They're not getting the right care. You see people, the comments like, oh, doctors and nurses, they're sitting around, they're smiling, all sorts of things you hear from the public. So, yeah. We don't, if you want to clap for us every day, 367 days, it's 365 days of the year, not just, The daily briefings, they were giving the public sort of a picture of as to what was going. But again, were they not aware of what was going on before? Because it was interesting to hear the briefings, but it was also interesting to sort of hear the naivety of actually what goes on in the work within the hospitals. Because on a daily basis, yes, obviously things were heightened. It was very different in COVID. The things that some of our colleagues saw and experienced, you would never dream of experiencing those things. They were in a war. But they do that any day, and and to think that, the NHS was so it's always been short-staffed. The last 5-10 years, it's always about staffing, it's always about beds, but yet we carried it through. We kept going and, saved people and kept the institution going. And these were the people at the forefront. It wasn't the managers, it wasn't the people who sit in the board, it was the frontline workers. So, yeah. Because I was shielding and watching sort of hearing stories from fellow colleagues, watching documentaries about how it was the circumstance that they were going through. And, well, it's been hard. Mentally at one stage, I felt very, again, I mentioned earlier, I felt like I was a traitor. I was getting the easy way out. I was sitting at home, not being part of that, not experiencing what my colleagues were feeling, the pain, the exhaustion, the pressures. And so I felt very guilty. I think mentally that made me feel very guilty. And talking to colleagues, and I couldn't say, look, I know what you feel. I felt I couldn't even reassure, what do I say? I'm fine. I'm sitting at home watching it on TV, hearing about it. So the impact of that had a big impact. I was even more determined, that's why, to get back out there, to get back out there and support my colleagues and support my friends. And I've lost a couple of colleagues, which, again, it was heartbreaking from one of them who I was a student of, and she passed away. She caught COVID, and it was devastating. And then everybody did a tribute, and I couldn't be there to even be there, and even going, you know, you wouldn't be allowed to go and see her, but be there, you know, be in my workplace where she worked. So those sort of things, it really brought it home that, wow, you know. And I've missed my chance of seeing her, to say goodbye, because I wasn't there. And that is heartbreaking. It's heartbreaking. It is very heartbreaking. My life now just focuses on inequalities, even at work. I mean, I just go on about it because I think it's so important within our services to talk about it and make sure that there are policies, procedures, things in place to support the diverse communities and make sure they get the same treatment as everyone else, whether that be pay, because there is a pay gap, whether that be career progression. You know, things need to be open and transparent. So that is something that, yes, I've been involved in, but not the other things, because I think inequalities, reducing sort of the disparities, it all ties in. It all ties in. I think this report coming out just recently, I think it was just amazing because we've had so much acknowledgement, and we've had senior most people within our professions acknowledging us. And we never ever thought that, it's not even a year. So it's opened up doors, and it's about not being invisible anymore. And it's about making that difference, because that's the whole purpose. It's not about me, it's about the future workforce. It's about my daughter or my sister not being a statistic, because we want to make that difference. So, for instance, we created 2 safe spaces, 2 safe sessions for our colleagues to come and talk. And for many of them, they bottled these experiences up for years. So, because they felt it was safe, and it's like they've been liberated, and it's sharing those experiences, because unless you have evidence, it's very hard to go out there, because people are fearful, people are afraid. And we hope to do this again on a wider scale to get more experiences, because the NHS, I mean, I know many surveys are done. We have the staff survey, but we're not going to, we're not going to say these things because you don't know the consequences. But at least we are a private entity, we are an independent entity, and people feel safe about talking to us. And we can actually, through this report, engage in with everyone without having that restrictiveness or worried that, someone's going to say, well, no, you can't publish that report, you can't do this, and we will get, I think, more people trusting the organisation and sharing their experiences, because it's very important to share these experiences. It's very powerful. People don't, when people hear these experiences, they've got nothing to say. So within the report there were some very, very awful comments that have been made to people. For instance, midwives who wear the hijab, for instance, being told that, do you come from a terrorist background because they wear a hijab? So things on that line. And facing discrimination, facing racial comments all the time. And this is like, it's acceptable. For instance, one person said that every time a South Asian woman came in labouring or came onto labour ward, she was the only South Asian on that ward, they would shout across labour ward and say, come on, you need to go to that room now, you need to go and look after your own kind. So it's things like that. And they are powerful. And I know we received a response back from senior person from an agency, and they said in response that it was shocking to read the report, and she apologizes. She apologizes that people still have to face these sort of behaviours and attitudes, and we need to move on and actually do something about it. So you have representatives, you have freedom to speech, but the thing is, can we trust them? Who are they? Where are their loyalties? Because you'll be labelled. You know, our it's all confidential. You know, we won't be releasing names, and there's no need to release names or where people work. But within the NHS, they'll know who it is. They might say it's confidential, but we know it's not hard to work out who's saying this and who's not saying this. I think one of the big things that needs to be done is to create a cultural, competent and safe environment, and that needs to be done from the top. So there has to be the guidelines, the policies, everything has to have that element of cultural competency and safety. So it's about making people aware as well. I mean, everybody has biases. Everyone has unconscious bias. And it all relates to how they've been brought up, what environment they've been brought up in. But it's about making them understand that we are a caring profession. So, you know, that is what we, you know, why we're in this job. So everybody, all people, irrespective of race, sexuality, religion, culture, tradition, they should be all treated equally with respect, and they should have the equitable care that we're supposed to give them. I mean, one of the things that we abide by is do no harm. Well, for me, we are doing great harm if we're looking at statistics like we're looking at, you know. So it's about making that awareness and making it mandatory for everybody to go on these training programs. You know, in the NHS, for instance, midwives, we have to go on mandatory training every year. And I think this should be part of it. And it's not just in the trust. It should start from school. You know, you have to embed these sort of awareness into everybody. You know, midwifery, nursing, medical curriculum should have this as part of their structure. We have to hold management accountable, because they are giving out they are saying that, yes, we've got all these structures in place to deal with these, the HR structures, everything is there. But actually, it's just a tick box exercise, because I know many people have been suspended, and, you know, many people from the diverse sort of communities, staff, have been suspended because they've been accused of X, Y, and Z. But, you know, they didn't have the support, the guidance, or they weren't even told, or they're not even given progress, but they were suspended because they were black or brown. And if you look at the GMC, if you look at the NMC, you know, the number of someone coming from a diverse background is more likely to face the GMC and the NMC. So we know that. So there needs to be representation within these institutes. It's like with the NHS. You need black, brown people in the board level, not just at middle management level, because unless you have that representation, these things are just going to go, you know, just going to be swept aside. So it's about creating a institute with these policies, these guidelines, legislation has to be in there, and everyone has to be accountable. The institute, the organisations have to be held accountable for these behaviours, these attitudes, and it should be fair. As I've said, the NHS is an amazing organisation. You know, it is. It's. We are very lucky to have an organisation that gives us free care, number one, and so-called equitable care. I mean, yeah, the work we do is fantastic, but it's about the people within it. So my vision would be to be a fair, organisation which is void of structural racism. We have to create cultures that aren't racist or discriminatory, and because look at its workforce. I mean, a large part of the workforce is people from cultural diverse backgrounds. So respect them, give them what's due, and treat everybody the same, and be fair and equitable.